So most of the people who are watching this antenatal class will be attending us for their pregnancy care at the Scotia Clinic in Tralee. And for anyone who's attending for pregnancy care within the HSE service, they receive this book on pregnancy information and labour information. It's an excellent book. So we would recommend that maybe during your lockdown you dust it out and read it a little bit. There is one other book that we usually recommend for our patients as well. It's called the Irish Pregnancy Book, and it was written by Dr. Peter Boylan, who would be well known to a lot of people, an ex-president of the Institute of Obstetricians and Gynecologists. And it very much mirrors how we practice antenatal care and pregnancy and labour care in our practice. The majority of patients and women that come to us, we hope will come in spontaneous labour. When people come in spontaneous labour, they usually come with a combination of symptoms, which might be contractions which become gradually more frequent and more long in duration. Sometimes they might have a show which is passing some blood, and sometimes their waters might go. When you come to the hospital, the diagnosis of labour is usually made by a midwife who examines you to see if the cervix has started to open up in labour. Then we talk about the first stage of labour, which is from the time you start to dilate up until you are fully dilated. During that time, for the first stage of labour, our patients, if they're very low risk and have no complications, might be intermittently monitored in labour so that the baby's heartbeat is listened to on a regular basis. And we monitor to make sure that the baby and both mother are healthy. We try to encourage people to be as mobile as possible for as long as possible in labour, because when you walk around it helps the head to come down. Obviously, some people will need some form of pain relief in labour. Not all women, but there's a variety of methods of pain relief open to women. The longer people stay at home, the better, because when they come in labour, then they usually are very well established in labour. We encourage people to look at the option of a TENS machine, which you can rent out to use for the duration of your labour. Our patients rent from Tralee Physiotherapy Clinic in Tralee, and when you collect your machine, the physiotherapist shows you how to use that machine. TENS is best used if it's put on immediately after labour starts, as the benefit is there from the beginning. Some people, rather than using TENS, might like to be mobile at home. They might like to be on their gym ball. They might like to be in a bath of water or have a shower and use natural methods, reflexology, acupuncture and aromatherapy at home. And hypnobirthing would be another method that a lot of women would use. So we encourage all of that. But for some women, when they are in labour, they need more than that as methods of pain relief. And we have other methods that we use. Pethidine is an injection that can be given at any stage in labour. It's an injection given into the thigh or the buttock. It can make the baby a little bit drowsy. It can make the mother a little bit drowsy. It doesn't take the pain away, but it can help to relax people. Other methods could be using Entonox gas and air, and that's a mixture of liquid nitrogen and oxygen, and women breathe the Entonox with each contraction. Its effect is immediate and it wears off very quickly. It can make you feel a little bit woozy, but it doesn't have any long-term effects. People can use it at any stage in labour. We find it perhaps very beneficial at the very beginning of labour while people might be waiting to see if they have an epidural, and we find it very beneficial in the second stage of labour before people start to push. Obviously, an epidural is a method of pain relief in labour that a lot of women are very aware of, and there are videos that we will have links to that you can watch on our patient portal, and there is a website called www.labourpains.com that has a lot of very good information on pain relief in labour. So when people get to 10 centimetres, we regard then that they're fully dilated and the second stage of labour starts. Often we divide the second stage of labour up into a passive stage where people allow the head to come down naturally of its own accord, and then we might have an active second stage of labour where people push. Obviously, the longer you can allow the head to come down naturally, the less pushing there may be. But you have to be guided by your midwife, who might have a reason to want to get people pushing a little bit sooner. It might be that the baby's getting a little bit tired. It could be that the waters have been gone a long time. There will be a variety of reasons for it. So once people get to the point where they have an epidural or any other intervention in labour, such as an oxytocin drip, or if the waters have broken and show meconium, then we often swap from intermittent monitoring in labour to continuous monitoring in labour. And in that situation, there is a belt around the mum's tummy, and she's attached to a monitor that continuously monitors the baby's heartbeat, so we can be reassured and see if we need any interventions. So we're looking at the rate of the baby's heart. We're looking at whether it accelerates, whether there's any decelerations where the heart rate goes down with contractions or other issues. So it helps us to make sure that your baby is healthy in labour. Other things people might need to know about is whether they would have an assisted delivery in labour. Naturally, we would like everybody to have a normal delivery, but there are circumstances where people might need to have some assistance in labour with either a vacuum delivery or a forceps delivery. That could be because the baby has become distressed, or it might be because the mum has high blood pressure, maybe a heart condition, or some reason why we don't want her pushing for a prolonged period of time. Or it might be that you've been pushing for a long period of time and you've got tired, and everyone feels that giving you a helping hand would be a good idea. And about 1/5 of women who come into labour ward in active labour may have an instrumental or assisted delivery. The most common one that we use is something called a vacuum delivery, and the most common vacuum delivery that we use nowadays is a disposable kiwi cup, and this attaches to the top of the baby's head, and a vacuum is attached to the baby's scalp, and we help to ease the head down as the mum is pushing as well. And that is it's not in any way dangerous to the baby. Sometimes they have a tiny little bump on the top of their head afterwards for about 24 hours. You still have to do a little bit of pushing, but we help with doing a lot of the work. There are other kinds of vacuum, but kiwi would be the one that we most commonly use. Sometimes people can't push for us even though they're trying very hard. It might be that we need to move a little bit faster than just with a kiwi delivery. So sometimes we use forceps, and the forceps are like metal that wrap around the baby's head, and you help us to ease the head down and out of the pelvis. So they would be the usual forms of assisted delivery that we embark on. The third assistance that can sometimes be given to women is a caesarean section. And we know that caesarean sections might happen in a planned environment. People might have a planned caesarean section because their baby is breech, because for whatever reason they shouldn't have a labour. They might have had previous surgery to their uterus, the placenta might be low lying, or the baby might be very small and it mightn't be appropriate to allow labour to continue. Sometimes it might be that the mother has a medical condition that precludes allowing labour to happen. So a planned caesarean section is an elective caesarean section, and in that situation our patients come into University Hospital Kerry, or if you're going to another hospital it might be a different hospital, but the processes will be very similar, and you come in a planned fashion on a planned day for your caesarean section, and you go to theatre, hopefully with your partner or another birth companion, and we by and large use a spinal anaesthetic where it's an injection into the back that numbs you from the waist down to allow you to be awake for the delivery. And we have a very good video that we are going to put up on the site for you to watch the stages of a planned caesarean section. Where at all possible for all our caesarean sections, we try to practice gentle birthing in our department. Gentle birthing means that the baby is delivered as gently as possible, brought to you as quickly as possible and allowed to have skin contact with you and your partner in the labour ward. And if the baby wants to feed and you want to do some breastfeeding in the labour ward, we obviously encourage that. So where at all possible, gentle birthing is something that we work with, and it works particularly well for planned caesarean sections. Sometimes women have emergency caesarean sections, and this might be where you come in labour and your baby gets tired or your blood pressure alters, or for whatever reason we decide that we need to do a caesarean section very quickly. If you have an epidural in place, which you might have had put in for the early stages of labour, the epidural can be topped up to numb you so that you can have the procedure done. Alternatively, if you haven't an epidural, the anaesthetist may place a spinal anaesthetic, like I've mentioned, in your back to numb you. Very, very rarely nowadays do people need general anaesthetics, but there are circumstances where it is necessary, where we need to do the caesarean section so quickly. Or, for example, there is some history of spinal surgery where the spinal anaesthetic cannot be safely placed. If we were anticipating that kind of scenario, you would probably have seen an anaesthetist during your pregnancy to assess the situation. With a caesarean section that's an emergency, it does work very fast and we move very fast. It can seem a little bit unnerving to people, but everything is done in the interest of mother and baby, because we want a healthy mother and healthy babies. There will usually be a paediatrician at a caesarean section delivery to check your baby out immediately, and there is always a midwife with you there as well. So they're the reasons by and large that we would be doing a caesarean section. Like I said, maybe the baby got tired in labour, maybe we noticed meconium where the baby has pooed into the liquor, maybe the labour isn't progressing and you're just not advancing in labour. It might be just a very big baby, and sometimes for maternal conditions as well. So where at all possible, we're trying to avoid caesarean sections, but as I said, healthy mother and a healthy baby are the most important things for us. Then another important group of women I wanted to mention are women who've had a caesarean section in the past. Just because someone has had a caesarean section in the past doesn't mean that they have to have a caesarean section again the next time. We refer to that, we use the phrase VBAC, vaginal birth after caesarean section. So if someone has had one caesarean section in the past and there's never been a reason that they can't try labour again, we encourage them where possible. And we know that about 75% of women who embark on a VBAC, where everything is in the circumstances are right for it, then we would be really actively encouraging a VBAC. For example, if you have had a labour before and you've delivered normally or vaginally before, if you've had a VBAC before and you start labour yourself, is one of the most important things to be aware of, because when there's a scar in your uterus, we're very limited as to whether we can induce labour or not. So with our patients, we try to encourage VBAC. Sometimes people feel that they just know that they will have a caesarean section regardless. And I think we would like to take the opportunity with you during your pregnancy to look at whether you're suitable for VBAC or not, and trying to encourage you. But the important thing is starting labour yourself. That would be the most positive thing. If someone has a scar on their uterus, is a very, very small risk of the scar rupturing in labour, but that's why we monitor you closely. The baby is monitored continuously. Your blood pressure, your pulse, all of those things are monitored. If we use oxytocin in labour to strengthen the contractions, we're obviously very judicious with the use of it if there's a previous caesarean section scar, because again, it's always about doing everything as safely and as healthily as possible. One last area that would be nice to cover would be what's involved in induction of labour. About a fifth of women may have their labour induced. The reasons that we would induce labour would be because you've gone overdue. That would be a very common reason. Where at all possible, we try to give people the opportunity to go into labour themselves. So we would maybe let you go overdue by about 10 days or so to see if you would start labour yourself. The other reason why someone might be induced is because we're concerned about the baby. It might be a little bit small, it might be a little bit big, and we feel that waiting for labour to start itself mightn't be safe. And we would induce in that situation. And sometimes there are reasons that the mother might need an induction process started for her. She might have preeclampsia, she might have diabetes, and we might feel that it's in the best interest of the mother that labour would be induced. So when we talk about inducing labour, that's starting the process for you. The most common way that we induce labour nowadays is using prostaglandins. These are hormones that your body would normally produce in labour, but we can insert them into the vagina through a gel, and then we repeat that gel process a couple of times, maybe over a period of 24 hours, and we wait to see will the cervix soften and will contractions start of their own accord. We also have a specific prostaglandin nowadays called Propes. This is slow release, and it's put into the vagina for 24 hours and then taken out at the end of the 24 hours. Obviously, if you go into labour before the 24 hours, we take it out. After the prostaglandin process, the woman is examined and we see whether the cervix is open enough for us to rupture the membranes, because that releases your own natural prostaglandins. And it allows us to see the colour of the fluid around the baby, and it's the next step of induction. And for a lot of women, that might get them into labour. But we also use oxytocin drips if the contractions haven't started with the rest of that process. Again, through all of that, you're carefully monitored and your baby is carefully monitored, because we don't want you to over-contract and we don't want to do anything that will distress you. We also know that if someone starts with an induced labour, they're more likely to need pain relief in labour, and they're more likely to need an epidural. So one intervention, medical intervention, can lead to another one. So that's where it's all possible. We're trying to encourage people to start labour spontaneously themselves. So we hope that this clarifies a lot of the processes that happen in a labour ward. And we hope that if you have any questions after watching these videos, that you feel you can email us and we can go and do a conference call with you or a Zoom consult. And the very best of luck when you do come into us in labour over the next few weeks. Thank you.